Hello, good morning or good afternoon, whatever the case may be. Well, this is Dr. Romulo Aguilar, and for this session, I will be discussing with you the different modalities by which we can visualize the ocular fundus. Before we start, I hope everybody is well as your families, and please do continue to keep safe. Okay, the objectives for this session would be to discuss with you the different modalities by which the ocular fundus or the retina may be visualized. I will be elaborating on the principles and the technology behind the different examination modalities, also describe the techniques of examination, and review the indications for their application. I will also be presenting basic concepts in reporting and/or the interpretation of examination findings. This will be the outline of the session. So we will be discussing three main modalities: ophthalmoscopy, slit lamp biomicroscopy, and optical coherence tomography. Under ophthalmoscopy, we will be discussing direct as well as indirect ophthalmoscopy. For slit lamp biomicroscopy, we will be discussing the type of lenses that are used in conjunction with the use of the slit lamp in viewing the retina. And finally, the use of optical coherence tomography. So when we want to visualize the external eye, it is pretty straightforward. Direct visualization usually would suffice. Take out your pen, light up the external adnexa, and you can see most of the structures already. On occasion, you would need a magnified view, in which case you'd need the slit lamp or biomicroscope. There are other ancillary procedures that can be used to visualize some of the other structures of the external eye, but generally these two methods will suffice for viewing the external eye. But then, question is, how do we visualize the internal structures of the eye, or the ocular fundus, or the retina in particular? Of course, we can attempt to do direct visualization. As these two guys are trying to do, they stare at each other's eye, hoping to see the retina inside. Now on this, let me bring up the concept of near point. So the near point is defined as the closest point at which an object can be placed and still form a focused image on the retina. This is about 25 centimeters or 9.8 inches. Adjusting for the axial length of the subject eye and the examiner's eye, the distance between both eyes will be about 8 inches. Okay, so 8 inches away, there is a possibility that the object will still be focused on the retina. So these two guys are trying to do that. It is about, would you say that was 8 inches? But after a while, you will see they turn away because it simply doesn't work. Why doesn't it work? The drawback mainly comes from the pupil. Because of the small aperture of the pupil, the area that can potentially be visualized is rather small. And number two, the pupil will not allow so much light to enter. Therefore, there is poor illumination. Let us discuss this a little bit more. Let's discuss the effect of distance on field of view. So this is the examiner's eye, and you have here the subject's eye. And let us assume that they are 8 inches apart. 8 inches apart, the subject's retina can still be focused on the examiner's retina, and the field of view will be as big as this. When you go closer to each other, you will see that the field of view may be a little bit bigger. Actually, If you compare the chord lengths of the different fields of view, you will see that moving closer, you will be able to potentially see a larger part of the retina compared to when you are far away. So this is the effect of distance. How about illumination? We should remember that the eye, in order to see, needs light. I mean, if you turn out the light, then basically you don't see anything. Now, let's also remember that there is no illumination actually inside the eye, so it's dark. So whether the eyes are close to each other, it is nearly impossible to see the contents of the eye. So what we need to do is illuminate. So there should be an instrument that would deliver light inside the eye and therefore illuminate the contents. Then we have a greater chance of being able to see the contents of the eye. So this gets reflected back into the observer's retina, but then there are limits to how much the lens can accommodate. In a very short distance, the distance might be too near for the lens to compensate. So what has to be done? You put additional lenses to compensate for the lack of accommodative power of the lens in working for close distances. And this is actually the principle or the concept behind the ophthalmoscope. So there are two types of ophthalmoscope. You have your direct ophthalmoscope here and your indirect ophthalmoscope. And we will be discussing this in detail in these succeeding slides. So direct ophthalmoscopy is the technique used for visualizing the fundus using, of course, the direct ophthalmoscope. The indications for this use are if you want a high-power study of the disc and macula or any other structure on the retina, if you want to measure elevations and depressions, and this is largely dependent on the type of ophthalmoscope you use. Some ophthalmoscopes would have slit beams so that if you shine the slit on the retina and it curves backward, then you know that that part is depressed. If it curves forward, then you know that that part is elevated. You can measure the dioptric power of the eye, meaning to say by focusing and turning the focusing wheel of the ophthalmoscope, you can determine whether the patient is maybe myopic or hyperopic or emmetropic. And it can be used to study small lesions because of the relatively large magnification that direct ophthalmoscopy gives. So here are the advantages and disadvantages of your direct and the disadvantages. The advantages are, as I said, high magnification, about 15x. It gives you an erect image. You can have measurement capabilities, as I said earlier, and it is relatively easy to learn. The disadvantages are the small field, only about 10 to 12 degrees, so that you can only view structures posterior to the equator. There is relatively poor illumination, although newer direct ophthalmoscopes would have brighter light thanks to LED technology, but then these are sometimes not enough really to bypass the media opacities like cataracts. Major disadvantage is monocular because you only use one eye at a time, and if you try to look at the periphery, there will be a lot of distortion. Now, basically, the technique of direct ophthalmoscopy was probably taught to you when you were students, so let us quickly just review it. You have the patient sit down comfortably and fix at a certain object at a distance. You dim the lights of the room because you want the pupil to dilate a little bit, or if it is permissible, you can pharmacologically dilate the pupil. You now rest the ophthalmoscope against her cheek, holding it with the right hand. If you're examining the patient's right eye, then you use your right eye. If you're examining the patient's left eye, you use your left hand and your left eye. So it's right, 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 left, left, left. Stand obliquely to the side because you do not like to cover the fixation of the patient. Then slowly, from a distance, you move closer to the patient, and your guide is the red-orange reflex. First, look for the red-orange reflex, and then slowly move in towards that direction. When you're close enough, like this, you can start now trying to look for a vessel and focus on that vessel by turning the focusing wheel of the ophthalmoscope. Now, in this picture, this is relatively close, but actually you can go closer. Personally, my endpoint is when this finger touches the patient's cheek. Remember the effect of distance. So basically, the principle is the closer you are to the patient's eye, the greater the chances that you will be able to see a larger part of the retina. So try to go closer than this. And finally, when you see the structures of the fundus, you again focus. You probably will see a nerve. You follow it to the optic nerve. I'm sorry, you probably will see a vessel rather. So you follow it to the optic nerve. And then from there, you can examine the different quadrants first and examine the macula or the fovea last because it's going to cause intense glare to the patient so that if you examine it first, then the patient might move away from you. For you to have a better understanding of the technique of direct ophthalmoscopy, you can scan this QR code and then just watch the video later on. I will be distributing the QR codes later. Now, the question arises, how is it possible to visualize the fundus stereoscopically or three-dimensional viewing of the fundus? Okay. Here, let us first discuss the concept of stereopsis. Stereopsis is the perception of depth and three-dimensionality. Now, the basic requisite for stereopsis is a pair of optimally functioning eyes. Now, very basic concept is that you have your left and right eye looking at objects, okay? So you're looking at Wonder Woman and this guy here, and they are practicing social distancing. And the images formed on the left eye or the left retina and the right retina would be different. You see here, they're different. This is what you call retinal disparity. Now, these disparate images are now interpreted by the visual cortex. And from there, you now perceive depth and three-dimensionality. And that is, putting it in a very simple way, the basis for stereopsis. Now, there is not much problem when looking at far distances because the eye is relaxed, there is not much movement, provided, of course, that visual acuity is optimal. Problems may arise when you try to stereoscopically see near objects, in particular if you want to see the retina stereoscopically. The limitations for looking at near objects would be three. One is the near point. We discussed that. So anything closer than 8 inches, the eye will have difficulty focusing on already. Number two is the fusional vergence amplitude. The inward rotation of the eye is limited to a certain degree. So you cannot deviate it more than is normally possible. And number three, the amplitude of accommodation. The lens can change its shape only again to a certain degree. Beyond that, it cannot focus anymore. So these are the three limits for stereopsis for near objects. So what are the basic principles for seeing the fundus stereoscopically, assuming that we want to see it up close? So we have to neutralize the limitations. We neutralize the near point, vergence, and accommodation. And how do we do that? By moving the object farther away. But if you do so, and you still don't converge or accommodate, then your line of sight will go past the object that you want to focus on. So, the best thing to do here is find a way to bend the line of focus so that it would enter the eye and you can see now the retina. And how is this done? This is done like magic with mirrors. Okay? There will be reflecting mirrors that would bend the line of sight and bring it all the way inside the eyeball to the retina. Now, this is basically what you will find in the head gears or the head pieces of your indirect ophthalmoscope. You have reflecting mirrors there. And then, of course, there is the requirement of illuminating the internal eye. So you have a light source which would illuminate the eye, and then you have to focus, okay? Because uh, the mechanism or the distance will not allow you to focus very much on the details. So you bring in a lens, which we call a condensing lens, and finally an image is formed somewhere between the lens and the examiner. This is a favorite exam question. So remember, the image is formed somewhere between the lens and the examiner or the eyepieces. So this, again, putting it in a very simple way, as the physical optics or the physical optical principles of your indirect ophthalmoscopy. If you want to know more about it, then again, I'm giving you a QR code which you can scan and you can watch the video later. So indirect ophthalmoscopy is a technique of visualizing the fundus with the use of the indirect ophthalmoscope. Indications would be the presence of media opacities. As we said, it has stronger light, so it can penetrate moderate to mild cataracts. When the patient has high refractive errors, you can use it on children. If you want total fundus examination, meaning all the way to the periphery, and if you want to examine large lesions, because with large lesions, with the use of the direct ophthalmoscope, you might just see part of the lesion, and you will not be able to outline the whole lesion. The advantages would be the wide field, so you can now view anterior to the equator. Strong illumination, as I said earlier, you can penetrate media opacities, and of course, the most important advantage would be stereopsis. Disadvantage would be the low magnification. The inverted image gives the examiner so much confusion, especially if you are just starting to learn the technique, and it is difficult to learn. The essentials for doing a good binocular indirect ophthalmoscopy are: number one, the pupil should be maximally dilated. You should have control of the patient's eye. If the patient keeps moving the eye or there's nystagmus, it might be difficult for you to perform indirect ophthalmoscopy. Preferably, you should have a small pupil ophthalmoscope. And I think most of the currently available indirect ophthalmoscopes have the small pupil capability. And then you should properly adjust the ophthalmoscope before using. And how do you do this? So first you adjust your headpiece, and then you adjust the pupillary distance. There are adjustments underneath which would slide outwards or inwards. You try to focus on an object. Usually it's your thumb. If you see a black line in the middle, and then your pupillary distance might be too far apart. If you're seeing double, then you might have pushed the mirrors too much inwards, so you're seeing double. So you should see a single image like this. After that, you adjust the light, the level of the light. So there's an adjustment lever here on the side. This is too low, and this is too high. What you should aim for is this one. a single image with the light right about the center. When you've done that, then you're ready to do your examination. So the technique is you ask the patient to lie down and you stand above the patient's head. When doing the examination, always have your arms stretched. That is the proper distance from your headpiece to the condensing lens. And then you move as a unit. When you have to move around, you maintain the stretched arm, you maintain the relationship between lens and your headpiece. You can use your thumb to open the eye. Now, the distance of the condensing lens should be just enough to focus. This is too far, and this is too near. The distance of the condensing lens would be right about this one. Now, let's talk about the condensing lens. The standard lens, which usually comes with the indirect ophthalmoscope, would be your 20D or your 20 diopter double aspheric lens. And this is the picture. Now it can come as a yellow tinted lens, and this was developed because they say it would decrease light scatter, it would enhance contrast, and it's more comfortable to the patient. So it's your option whether you get the clear one or the yellow tinted one. There is an option of buying the lens with an adapter set. There are clip-ons. You can clip on a yellow filter, so it becomes a yellow colored lens, or you can clip on additional uh, lenses to transform the 20D into a 16 diopter, a 24 diopter, or a 28 diopter lens. Alternatively, you can just buy the lenses separately. So as I said, you can buy a 14 diopter, a 28 diopter, or a 38 diopter. What's the basic difference? The higher the power, higher the diopter power of the lens, you will have a wider field of view, but smaller images. So here, I tabulated the specifications of the different lenses, from your 14 diopter to the 30 diopter. There are two manufacturers or favored manufacturers of these lenses, your VOC Optical and Ocular Instruments. There are other brands, but these are the more popular ones. So you will see as the power increases, the image decreases, but the field of view also increases. Again, 20 diopter lens is the standard. You can opt to get an extra lens, a 28 or a 30, depending on your needs. Now, this figure shows you the extent of what you can see with the different lenses. So this is the extent of the full fundus. With the 14 diopter, this is just what you can see. With the 20 diopter, the standard, this is what you can see. That small yellow dot there is the optic nerve. 28 diopter, a little bit wider, and the 30 diopter, a little bit wider. Okay, so it's about 58, 75 with dynamic examination compared to 46 and 60 with a 20 diopter. Again, for a video on the technique of indirect ophthalmoscopy, you can scan this QR code and view it later. So you've seen the fundus with your indirect ophthalmoscope. It's time for you to report your findings. In reporting your findings, you must use what we call the retinal chart or the Amsler-Dubois chart, and this is how it looks. You have 3 concentric circles, and we will discuss what they represent later on. And you have 12 radial lines, 1 line for each clock hour. So from 12, 1, 2, 3 all the way to 11 back to 12. Okay. Some retinal charts will have a fourth small circle here that would represent the position of the optic nerve. Some will not have it, so it will depend on you where you will draw it, depending on whether you examine the right eye or the left eye. Now, just a tip, if you draw an imaginary line connecting the 12 o'clock and 6 o'clock, if you see this small circle to the right of that imaginary line, then this chart is for the right eye. If you see the small circle to the left of the vertical imaginary line, then the chart is for the left eye. Okay? Similarly, if there are no small circles there, if you're examining the right eye, then you draw the circle or you draw the disc to the right of the imaginary vertical line. And if you're examining the left, you draw the small circle representing the optic disc to the left of that imaginary line. Again, if you extend the line 12 to 6 and 9 to 3, it will intersect right at the center. And that is where the fovea should be. So you draw the fovea there when you start drawing your retina. Now, what do the circles represent? The inner circle represents the equator. The second circle represents the ora serrata. And the third, the outermost circle, represents the pars plana. You might come across some charts where they don't have the outer circle, but you will see that the radial lines extend all the way there, but you don't have the outer circle. So that just implies that the more important circles are the innermost and the middle circle. Now, you can have an imaginary circle here, just inside the innermost circle, which would connect the ampullae of the vortex veins. And that would define your posterior pole. So let me superimpose this one. So again, ora serrata is the second circle. The innermost is the equator. And again, if you draw an imaginary circle just inside the innermost circle, that will define your posterior fundus. And then from that imaginary circle all the way to your ora serrata, that would define your peripheral retina. Again, the macula is smack in the center, the disc to its side. If you're examining the right eye, it's to the right. If you're examining the left eye, it's to the left. Okay. So let's attempt to draw. So here you have, again, what is this? Let's pretend that you did not see this one. So this one is the right eye because the disc is to the right of an imaginary vertical line. So if you draw a normal retina, this is how it would look. The macula is dead center. You have the optic disc. You have the ora serrata, which will coincide with the middle circle. Okay. Now you will see, if you will note, I'm pointing now to the ampulla of the vortex veins. So it is just a little bit posterior to the equator. You can see it also there. You can see it there, here, and here. If you now connect this with an imaginary circle all the way around, that would, as I said, define your posterior fundus. And the area from vortex vein all the way to the ora serrata will define your peripheral retina. One thing you should note also is that the ora serrata on the nasal side is more jagged in appearance compared to the ora serrata on the temporal side, which is more smooth. This is also a favorite examination question. Okay, so temporally it's more smooth. Nasally, you should draw a more jagged ora serrata. Again, superimposing the measurements, that's how it should look. And you will see this imaginary line connects the ampulla of your vortex veins. Okay, so what is the proper orientation of that retinal chart? If you're examining the patient sitting down, then you have to invert the chart. So this is 12 o'clock. The chart is inverted. 12 is down here. 6 is up there. This is in order for you to neutralize the inverted image when you start doing your indirect ophthalmoscopy. Alternatively, of course, you can invert the patient. That is why it is recommended that you have the patient lie down and you stand here above the head. And the chart should be properly oriented with 12 o'clock at 12 o'clock and 6 o'clock really at 6 o'clock. Okay, so this will again neutralize the inversion of the image, and the tip is just draw as you see it. Tips on fundus drawing. Again, I said disregard your superior, inferior, temporal, and nasal while drawing. Just draw what you see. Whatever appears closer to the observer in the condensing lens is more peripheral or more anterior. Observe the disc and follow the vessels to the periphery. And just like in direct ophthalmoscopy, observe the macula last because it's going to cause intense glare and the patient's eye might start moving. So let's just get an example. So this is the fundus of the patient. You have a small horseshoe-shaped tear and localized detachment at around 10:30. And the patient also has lattice degeneration at about 1:30. And this is how you will see it in the condensing lens. So there, no? So here you have lattice, which is located at about 1:30. This is how you will see it in the condensing lens, and this is how you will draw it on the inverted chart. Okay, so this is the ora serrata. You draw it around the second circle. You have the lattice there. Okay, so you see now on your condensing lens at about 10:30, you see a horseshoe shape there and a localized detachment. So you draw it as you see it here. And if you, once you complete your drawing, you will see that, and then just turn the chart right side up and you will see that you have drawn it correctly. Now, for you to learn more from this drawing, then you really have to practice, and you can attend our advanced sessions uh, maybe next year. Now, in drawing, we follow a color code, and this is adapted from the American Academy of Ophthalmology. We are giving this out as handouts, but to go over it briefly, blue will denote detached retina, retinoschisis, lattice degeneration, and retinal veins. Red would represent retinal arteries. Red outlined with blue would imply retinal breaks. Hemorrhage, microaneurysms, neovascularization, attached retina would be red. Although attached retina sometimes is just left as white. Brown for any choroidal lesion or photocoagulation marks. Green for opacities, vitreous opacities like vitreous hemorrhage, media opacities like cataract or corneal opacities. Orange for exudation, cotton wool spots, chorioretinitis, and yellow for edema. Let's look at some sample retinal drawings. So this is the very, very simple way to draw the retina. So in the right eye, you will have the preretinal hemorrhage there. These yellow dots would represent your exudates, I mean orange dots. The red dots are probably punctate hemorrhages or maybe microaneurysms. You will see, as I said, the nasal aura is more jagged in appearance. The, the temporal will have larger gaps or sometimes really smoothen out. Green here would denote vitreous opacity, maybe hemorrhage. On the left eye, you have lattice at around 10:30. You have a horseshoe-shaped tear at around 2:30. And you have detachment extending from about 2 o'clock all the way to about 7:30. Now, if, for example, this left eye, had some degree of cataract and there was media opacity, you can denote this by just putting these green lines, no? Cross it out with green lines. So that would denote that there is some media opacity obstructing a clear view of the posterior pole. Now here are more elaborate drawings. This was not done by any resident or fellow. This was taken from a book. Now here you will see almost total retinal detachment and a horseshoe-shaped tear anterior to the equator. Here you also have, there's another horseshoe-shaped tear there. Here you have a horseshoe-shaped tear also posterior to the equator, and lattice degeneration at about 12 to 12:30. Here, the specialist drew the vortex vein, and you have yellow dots representing exudates. Now, this was taken from a book, The Lost Art of Retinal Drawing. And I hope that your generation would revive that lost art and draw your retinal drawings as vivid as these ones. More examples here, brown, so it denotes choroid. This is choroidal melanoma with an associated retinal detachment. Okay, again, you will see, I cannot stress this more, the nasal ora serrata is more jagged in appearance compared to your temporal ora serrata. Here you have choroidal detachment. Here's an example of an eye with an encircling element, and you can see the indentation. This is how an indentation is drawn. And here you have an eye with laser marks and traction retinal detachment. So I hope to see you draw as good as this one. So comparing direct and indirect, this is just a summary of what we have talked about. Direct offers good magnification, 15x. Indirect, only 2 to 4, but it has a wider field of view. Illumination is high, penetrates media opacities, moderate to mild. Focus is deep, stereopsis is present, but the image is inverted in reverse and can lead to confusion. Working distance is an arm's length. For direct, you have to be really, well, close and personal with the patient. The view of the periphery is limited with the direct and is possible with indirect. And scleral indentation can be done with your indirect ophthalmoscopy. So again, with figures, we want to highlight this is the field of view you see with your direct ophthalmoscope, although the image is magnified, but the field is small. In your indirect, the field is large, is wide, but the images are relatively small. Now, another way to visualize the retina is by the use of the slit lamp. No? So if you don't have an indirect ophthalmoscope, it should not stop you from having a full view of the retina. If you have a biomicroscope, you can use that in conjunction with either contact type lenses or your non-contact type lenses. Let's start with the contact type lenses. The mother of all contact type lenses would be your Goldman 3-mirror lens. Okay. There are 3 mirrors. The central part is actually transparent, but for all intents and purposes, they sometimes refer to this as the first mirror. So the second mirror is trapezoid in shape. It is angled at about 73 degrees, and you can see from the posterior pole here to the equator. This is the scope of mirror number 2, the trapezoid mirror. Mirror number 3 is rectangular in shape. This one. It's tilted 67 degrees and it gives you a view of the equator up to the beginning of the ora serrata. Then mirror number 4, the shape of which is like a thumbnail or a parabola, you might want to describe it that way, is angled at 59 and gives you a view of the anterior chamber and the ora serrata. This is the mirror often used when you do gonioscopy because you can see the anterior chamber angle beautifully. Magnification of the Goldman 3 mirror is very good, but it is very tedious to use. Imagine if you want to see the retina completely, you have to use each mirror, turn the lens 360 degrees, so you have to turn it 3 times. Once for mirror 2, once for mirror 3, and then once for mirror 4. Other lenses have been developed. You have your centralis direct. The field of view is limited. It equals the central mirror of the 3-mirror lens. You have your quadraspheric. It gives you a super wide field of 130 degrees and is an excellent lens for panretinal photocoagulation. You all have a transequator, which has a slightly narrower field of 120, but better magnification of 0.7. Also good for PRP and macular grid lasers. Another lens is the area centralis. Its magnification is good and is excellent for macular examination or treatment. The field is up to the equator. So this is now a tabulation of the specifications of these lenses. Okay, centralis direct, good magnification. You only see the central retina. Area centralis up to the equator. Transequator is beyond the equator, as the name would imply. The quadraspheric is much wider at 130 degrees, but you sacrifice a little bit of magnification. But the widest field actually would belong to these lenses. Your Super Quad 160, your HR wide field, and your Mainster PRP 165. It's ideal for your PRP, and these are the specifications, and you will see they're not really that much different, but the Mainster PRP 165 is a shade wider than your Super Quad 160 and your HR wide field. It can have a field of view on dynamic use of as much as 180 degrees. Magnification is the same at 0.5. Again, a tabulation of the different lenses and their image magnification and their field of view. Okay? Super Quad is about 160, but the Mainster beats it at 165. And if you do dynamic examination, that means you move the lens around, you can go as high as 180. Okay, so that will be a guide on what lens you might choose to buy. Again, this is an illustration of how wide the fields of view will be for the area centralis, for the transequator, which goes beyond the equator, the quadraspheric, it's a little bit wider than the transequator, and finally your super quad, which actually almost reaches the ora serrata. And even wider than this would be your Mainster 165. Let's now go to your non-contact type lenses. So you have your digital wide field, and by the name, it gives you the widest field of view among the non-contact lenses. It views past the vortex vein, so therefore it views past the, or almost at the equator. Magnification is comparable to the standard 90D, and it has a small pupil capability. On the other end is your digital high mag, which gives you greater magnification, but a smaller field. So these are the specifications. Digital wide field, magnification is zero point 0.7, but the field of view is about 124. Your digital high mag, good magnification, but field of view is sacrificed to about 70 degrees. 90 diopter rather is your standard diagnostic lens. It's relatively cheap, and sometimes in some international conventions, these are actually given away. Now, other options would be your super pupil XL, which they say allows indirect ophthalmoscopy through the slit lamp. It also has a small pupil capability. And finally, your super field NC, NC standing for non-contact, will give you the widest field with the highest resolution. So probably it would be the better lens to invest in. So again, the specifications, your 90D has a field of view of only 69. Super pupil and your super field both have a field of about 120, but your super field will have bigger magnification. So you're a little bit more on an advantage with super field. I just like to bring to your attention the Superfield NC multi-adapter transformer lens set. I'm not sure if it's available again in the market, but I know that the manufacturers have discontinued it. But just in case you stumble upon it, then I would highly recommend that you invest in this transformer lens set. Why is it called transformer lens set? Because the basic Superfield NC lens can be transformed to different lenses with the clip-ons. So let's say, for example, you use the plus power non-contact. So it retains its non-contact characteristic, but it increases the field of view to about 130 degrees. If you now use the minus power non-contact adapter, it increases magnification, but of course you sacrifice the field of view. If you clip on the ultra field plus contact adapter, it now transforms the lens into a contact type lens, and it makes it similar to your quadraspheric. So very wide field also. If you clip on now the high resolution minus contact adapter, you get good magnification, which is ideal for work on the disc and the macula. And then you can have the lid lens adapter, which actually you can use to rest the lens on the lids, keeping the lids open, and at the same time fixing already the distance between eyeball and the lens. So you don't have to go forward and backward trying to look for the good focus for the lens. And finally, you can also clip on a yellow adapter for less glare. So in the world of non-contact type lenses, this would be the Optimus Prime of your non-contact type lenses. Again, in tabular form are the specifications of the different lenses. So if you want to invest in a wide field lens, you can go either with your digital wide field, your super pupil XL, or your super field. And hopefully you will be able to find the super field with a transformer set. For ocular instruments, the widest would be your max field 84 diopter. Okay, so you know what to look for next time when we can physically go to a ophthalmic convention. Again, these are figures to demonstrate the fields of view of the different lenses. Digital high mag, the 90D classic, a little bit wider. Your super field is even more wider. And finally, your digital wide field will give you the widest together with your super pupil XL. Now, how can one see beneath the retinal surface? We have discussed modalities for you to see the retina on its surface. But is it possible to see beneath the retinal surface? Here we discuss optical coherence tomography or OCT. OCT was first introduced in 1996. It is a non-contact diagnostic imaging technology that can slice the retina into very thin slices or cross-sectional images, which we call tomographic scans. It is analogous to your B-mode ultrasound, except that it uses light rather than sound. So some would refer to OCT as the optical analog of ultrasound. Now, the principal difference between an OCT and ultrasound is that light is a million times faster, or it travels much, 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 much faster than sound. Thereby, when you use light, the images that you produce would have much more better resolution than when you use sound. So just an example, if you want to see with sound, these are in quotation because you really actually don't see with sound, no? But in ultrasound, the sound is transformed to images. So if you want to see with sound, it is likened to taking a photograph while you are moving, but using a slow shutter speed or a slow film. And if you take this picture of an object, it is blurred and you can barely decipher what it is. But if you use light, this can be likened to taking a photograph even while moving, but you're using a fast film or a high shutter speed. Therefore, the image is clear. You can have it in black and white or grayscale. You can have it in color. Again, examples of seeing with sound. So here you have a vitreoretinal traction, but you don't see much of the details because the resolution is very low. Here, the resolution is high, and you can see the minutest detail of the vitreoretinal traction membrane and as it pulls on the retina. This is seeing with light. So, to give you an insight on the difference, let's review the basic principles behind ultrasound. So in ultrasound, there is a pulse generator that generates the sound waves introduced to a transducer, and the transducer now sends those or emits those waves all to the retina. It bounces back and is also caught by the transducer. It is now passed on to a receiver and to a signal processor, and then you have the final image, which would look like this. So that is, in effect, a simple way of explaining what ultrasound is. Now, for the basic principle of OCT, it's not very different. You have a source, but this time it is not sound, but a light source. Now, the basic components of an OCT would be your light source, your beam splitter, a reference mirror, an interferometer, and a detector. Okay. From the light, it is split the beam splitter. One arm is sent to a reference mirror. The other arm is sent to the target organ, in this case, the eyeball, or specifically the retina. The light reflects back, called the reference beam, and the sample beam, or the reference arm and the sample arm. This is received by the interferometer, which compares the reference beam and the sample beam and creates what is called an interferogram. So it combines light from reference and light from the retina and sends the interferogram to a detector. From the detector, data is acquired and processed, and you have the final image like so. So that is the basic principle. Now, the heart of the OCT principle is what we call interferometry. Now, what is interferometry? It's a process wherein the waves are superimposed causing the phenomenon of interference from which data is extracted. So for example, here you have interposed upon each other the reference wave and the sample waves. They're not really in sync. From there, this is generated what is called the interferogram. It's a physical and mathematical summation of the waves. And this is the heart of the OCT principle. Now, the OCT was first introduced in 1996. The first OCT was called the time domain OCT. This is OCT1, a sample picture from OCT1, and you will see that it is really quite grainy, or probably you'd say it's highly pixelized. Time domain OCT continued to develop. So in the later part of the decade, you have a higher resolution time domain OCT um, represented by your Stratus OCT. In about 2006, your spectral domain OCT was introduced and had better resolution at about 5 microns. This is your Cirrus OCT. And then at about 2012, the swept source OCT was introduced, and you have even better resolution. And you will see that it already approximates the true histological section of the retina and the fovea. Now, just a note, both the swept source and the spectral domain OCT are also referred to collectively as your Fourier domain OCT, and I will explain that later on. Now, what are the principal differences between OCT technologies? Let's start with the time domain OCT. Again, you see here the basic components of the OCT. But what would be the light source? Light source would be broadband coming from what is called a superluminescent diode, or an SLD. Light is brought to a beam splitter. Again, as mentioned before, one arm to the reference mirror, another arm to the retina. In time domain, the reference mirror moves back and forth. And then it is reflected back, processed in the interferometer. The interferogram is passed on to a detector. Data is acquired, processed, and you have the final image. You will see that the image from a time domain OCT, while relatively good, is still quite grainy. And this is because the movement of the mirror largely dictates the quality of the image. And the movement of the mirror can only go so fast. It cannot go as fast as the speed of light. And that's why you say it is time related, or it's time domain. So the time that the mirror moves back and forth is critical. When we go to the spectral domain OCT, what changed? Well, you still have the broadband light source, beam splitter, reference and sample arms, but here they fixed the reference mirror. The reference mirror is fixed. You again have the sample and reference arms going to an interferometer. The interferometer will give you an interferogram and passed on now not to a simple detector, but to what is called a diffraction grating. This is the process by which light is now separated into its component wavelengths. And from there, it is received by a spectrometer, which actually analyzes the spectrum. It's also called a spectrophotometer. And from here, a spectral interferogram is generated. And that is where it gets its name, spectral domain OCT. The spectral interferogram is now subjected to your fast Fourier transform, FFT, and you have the resulting image. which is higher resolution. Now you will ask, what is FFT or your fast Fourier transform? These are actually mathematical calculations done on the interferogram. And I'm sure you wouldn't want to go into a detailed discussion of this one. So let's go on and see swept source OCT. Basic components are there. What is different? First, the light source is no longer broadband. It is now a swept laser source. Having said that, it is now capable of giving out narrow wavelength or coherent light because this is now laser. So it sweeps through the spectrum of light and gives out the light wavelength by wavelength. And that is what reaches also the retina. So it is not white light, it is a narrow bandwidth already. Reference mirror is already fixed. And then, like in the other OCTs, reference and sample beam goes into an interferometer. Interferometer generates the first interferogram and is passed on, but you don't need the diffraction grating anymore because the wavelengths are already separated at the source. So you just have a balance detector. From there, a spectral interferogram is again generated, goes through FFT, and a very nice picture with high resolution and deep penetration. You will see here, this is already the sclera. So this is the choroid and the sclera. So the very deep penetration. In table form, this is the difference between time and spectral domain. So again, very briefly, broadband light source. For spectral domain, you use a spectrophotometer, which generates a spectral interferogram. Resolution, 400 pixels for time domain, 2048 pixels for your spectral domain. So you have better resolution. Spectral domain versus swept source. From the broadband light source, you have a swept laser, longer wavelength, and you will see the scan speed is doubled. 50,000 here, 100,000 for swept source, and that's why you have better resolution again for your swept source OCT. And that would explain the difference in the quality of the pictures. Now, what is tomography? We keep on saying optical coherence tomography, but what really is tomography? Well, tomography is the process for generating a tomogram. A tomogram is a two-dimensional slice of a three-dimensional object. Okay, so the best tomography that it's known to us would be computed tomography or your CT or your CT scan. And you will see here, the head is sliced, the thin slices, and it goes from one end to the other end. So this is what we're all familiar with. OCT similarly slices the retina thinly, which actually can be reconstituted to give you a three-dimensional picture of the retina. So this is the tomographic image of the macula and the fovea. Usually, the output of OCT is really in the grayscale. And you will see now how closely it approximates a true histologic section. On occasion, you will see reports where the tomographic image is colored. But this color is what we call false color representation. Now, what does that mean? Now, false color representation is anchored on the concept of reflectivity. Reflectivity is the proportion of incident light which is directly backscattered by the tissue. So, when light enters tissue, it behaves in many different ways and would emit the corresponding reflectivity. So let's say this is light. If it bounces back or reflects back, that is reflected light, and we say there is high reflectivity and is assigned the hot color red and also white. But light can also behave differently. It can go through tissue undisturbed, and we call that transmitted light. Or light can actually go into tissue and disappear, and we call that absorbed light. So when there is transmission or absorption, that would have low reflectivity and are assigned the colors black and dark blue. But most of the light will not behave like so. So most of the light will just go different directions. And this is what we call scattered or refracted light. And that would have moderate reflectivity assigned anywhere the colors orange to light blue. This just gives you sample of tissues and structures and their reflectivities. So scar tissue, because it's very dense, will be highly reflective. Similarly, your RPE, because it's a tight sheet of cells, will be moderately reflective. In contrast, your vitreous and aqueous, which will just allow light to pass through, so there's light transmission, would have low reflectivity. The rest of the retina will have anywhere from yellow to green to light blue in color because they will demonstrate low to moderate reflectivity. Here you will see what I'm talking about. The vitreous is usually black because it has very low reflectivity. The nerve fiber layer will be red because it has high reflectivity, because light usually bounces back from the layer of the retinal nerve fibers. Then the RPE, which is a tightly, uh, it's a tight tissue, the cells are tightly packed, will also give you high reflectivity. And the rest of the retinal layers will have yellow, orange, green, and light blue colors, all symbolizing moderate reflectivity. The choroid, sometimes also black because most of the light already absorbed by the tissues here. So very little light reaches the choroid, so it usually comes out as dark blue or black. But actually, with the swept source, light actually reaches the choroid. Where do we use OCT? It can be used to evaluate retinal diseases and the retina itself. It can be used to evaluate the optic nerve and the retinal nerve fiber in glaucoma. It can be used also to evaluate the cornea and the anterior segment. For this session, we would concentrate on the retina. So the retinal indications for OCT is when you want to study the anatomy of the macula and fovea in the various disorders. If you want to evaluate macular and foveal thickness, if you want to study the anatomy of the vitreous, choroid, and the vitreoretinal interface, if you want to monitor macular, vitreomacular, and other vitreoretinal disorders, and if you want also to evaluate post-treatment outcomes. Let us look at the tomographic histology of the macula. Histology is in quotation marks because this is not a true tissue section. So this is the normal OCT scan of the macula. As I said earlier, they're usually in grayscale, and colors are just falsely assigned. So you will see that you will delineate already, you'll be able to delineate the layers of the retina very beautifully. And of course, you can assign colors, as we said, and still see the layers of the retina. So very quickly, the internal limiting membrane, and then the retinal nerve fiber layer, ganglion cell layer. Next to that is your internal plexiform layer. And this green line is your internal nuclear layer. Then again, this yellow line here is your outer plexiform layer. And then this blue area is your outer nuclear layer. And this green line there is your external limiting membrane. And finally, this broad red line is your RPE. So there you have it, the layers of the retina. Next slide, we will focus on this part, the fovea. Now, when we look more closely at the fovea, again, we have identified the external limiting membrane and the RPE. But you will see there are also two hyperreflective lines in between them. The inner line is what is referred to as your ellipsoid zone, or sometimes also as your EPIS, or ellipsoid portion of the inner segments. It corresponds actually to this part. Okay, as you said, the ellipsoid portion of the inner segment. It is also called your ISOS junction because it corresponds to that part where the inner segments and the outer segments begin. So it's a junction between your inner segments and outer segments. This second line here is what is referred to as your interdigitation zone. So in the drawing, it corresponds to this part, the part where your photoreceptors interdigitate with the microvilli of your RPE cell. And that's why it is referred to as your interdigitation zone. So in evaluating foveal health, you have to also look at these zones and lines in the OCT. Now here is a beautiful slide which I grabbed off the internet, courtesy of Dr. Korsha, where she superimposed a true histological section on an OCT tomographic image. And you will see the correspondence. This is the RPE, and this is the true RPE. Interdigitation zone continues to here. This is the interdigitation zone just above the RPE. The ellipsoid zone, and then your external limiting membrane, and then your outer nuclear layer, which is composed of the nuclei of your photoreceptors. Then your outer plexiform, and then again your inner nuclear layer, which is composed of the nuclei of your bipolar cells. Then the inner plexiform layer, then your ganglion cell layer, and finally your nerve fiber layer. So this would encapsulate how beautiful OCT is in looking at the histology, quote unquote, of the retina. Now, just a few tips on basic interpretation. When you're given, let's say, an image like this, what you should do first is to assess centration, and then number two is to assess the integrity of the layers. Let's talk about centration. How do you know that the scan is centered on the fovea? Okay, you always look for this shape, the foveal depression, and not only that, you look at this tapered shape here, there, and this one, because you know that there are certain layers of the retina that are lost as you approach the fovea. So there is tapering. To emphasize, there. It reminds us of what? An hourglass that is lying on its side, or maybe a bow tie, or maybe a butterfly. Okay. Now, this configuration is never lost, no matter what happens to your fovea. For example, if you have severe macular edema, you have retinal detachment with macular off, you have central serous retinopathy, you will see the tapered appearance still. And just let me emphasize, there, here, and there. So if you see that, you know that the scan is centered on the fovea. Next, you evaluate the integrity of the layers. This is the same picture I showed earlier with well-defined layers. In certain diseases, you will see disruption of those layers. You will see cysts forming, elevations of the pigment epithelium. You can see like shredding of the layers. Going on, you might not be interpreting OCTs, but you might be receiving reports. So quickly, let's look at the parts of the report. Here you have the scan information. This one is what we call the en-face image or the surface image. Here is the B-scan picture. This one is the topographic map. It gives you an idea of the elevations and depressions, much like as a topography of land. So this is the reflectivity scale. Again, red and white would denote thick areas, like here, because it's thick. Now this one is your retinal thickness map and a certain scale here, which we will describe in more detail in the next slide. So normal retinal thickness will give you all green. There are numbers here which denote the thickness in microns. Now, green would denote that it is within 90% of the normal population. So it's normal thickness. If you see pink, this denotes thickness, and that thickness measurement belongs to the upper 1% of the population. No, same here. If you see pale yellow, that is also thick, belonging to the upper 4% of the population. Here. If you see red, that is very thin, belonging to the lower 1% of the population. And if you see bright yellow, that is also thin and belonging to the lower 4% of the population. So that's what the color codes mean when you look at the thickness map in an OCT report. You might receive an OCT report looking like this. Now, these three figures there is what you call your segmentation layers. This is the full thickness of the retina from ILM to RPE. This is only ILM, only RPE. And the reason that it's segmented like this is sometimes there are lesions that are present only in the ILM, but not in other parts. So you can now segregate where the lesion is. We've talked about this. Now this is your en-face with your topographic overlay. Okay, so the topographic picture is now overlaid on the en-face. You have two B scans. One B scan is a horizontal B scan. The other B scan is your vertical B scan. So by integrating both, you can have more or less a three-dimensional picture in your mind of what is happening to the macula or the fovea. For more about interpretation, you can again scan this code and read in it later on. Let's go over some clinical examples very quickly. I will be showing only pictures from swept source OCT and spectral domain OCT because I think your generation will no longer be using the time domain OCT. So this is an example for age-related macular degeneration. You have here the thickening, the choroid, most likely your choroidal new vessels. You have cystic changes, and again, here it's probably a choroidal new vessel. In the colored picture, the highly reflective areas are your choroidal new vessels, and you have cystic changes or disruption of your uh, layers. Example of macular edema, you will see that the retina is thickened. You will see broadening of this hyporeflective space, which means it's filled now with fluid. Same here, only it's colored. Here there is some neurosensory detachment and what we call cystoid changes. This is full thickness macular hole. Doesn't need further description. A lamellar macular hole. Drusen, swept source, spectral domain. These are drusens. Pigment epithelial detachment, swept source OCT. This is a big pigment epithelial detachment on spectral domain. Central serous, very typical finding. Neurosensory detachment of the central retina. Again, I call your attention to the tapered configuration, meaning to say the scan was centered on the fovea. Retinal detachment, macula on, retinal detachment, macula off. Vitreomacular traction on swept source OCT, on spectral domain OCT. Epiretinal membrane, you will see that membrane there. Okay, and on swept source, I hope you can see it. It's that hyperreflective line on the surface of the retina. Now, some OCT pictures, you can actually look at the movement. I'm not really the movement, but the scans as a movie. Like for example here. So you can see it's traveling here. You see that line? And this is how it will look. So slowly you will see the detachment and it reattaches when the cursor comes here. Okay, so this is what we call a movie. So it just gives you the series of slices rather as a movie. Advanced features would be your three-dimensional capabilities of your OCT. Now, just briefly, we'll discuss OCT angiography. It's not really, strictly speaking, it's not a means to visualize the ocular fundus. But since it uses the OCT technology, mainly spectral domain and swept source, then I'll just discuss it in passing. It's actually more related to fluorescein angiography, and I think you will have a separate lecture on that. And your lecturer might touch also again on OCT angiography in that lecture. So it was first introduced in 2014, and it's actually used to image the microvasculature. So there's finer retinal vessels and the capillaries. So as I said, strictly it is not to image the retina itself, but more of the vessels. Now it uses reflectance of the surface of moving red blood cells in order to outline the vessels. The principle involved is called your amplitude decorrelation and phase variance analysis. It looks very complicated, sounds very complicated, but let me try to simplify the principle for you. Imagine that, let's say, Metro Manila has a power outage, so all the lights are off. The only lights you can see are the headlights of the vehicles traveling or running on the streets, going home or wherever. Okay, so basically by following the car lights, one can trace and draw a map of the city streets. No? If you have a drone flying over Metro Manila, okay, you can more or less draw the street map of Metro Manila, similar to this. Okay, so just imagine the building lights are off and the cars are still traveling. So you can now actually reconstruct the city streets just based on the headlights of the cars that are traveling. So similarly, that is the principle behind OCT angiography. You follow the reflectance of the red blood vessels, and thereby you can reconstruct the blood vessels. like so. No? So you can reconstruct the larger retinal vessels and the capillaries on each layer. Okay, superficial plexus, the deep plexus, and even the choriocapillaries, or even outline abnormal vessels like a choroidal new vessel here, without using any dye. Okay, so in summary, I have discussed with you how the ocular fundus can be viewed using direct ophthalmoscopy, indirect ophthalmoscopy, slit lamp with the use of the proper lens, either contact or non-contact, and your optical coherence tomography. Now, these different modalities are based on varied principles and technologies, and each modality offers its own advantages, disadvantages, and ease of use. Now, the best examination method to be used at any given situation will be dictated mainly by the appropriate indication or indications for its use. With that, I end the lecture. Thank you very much for your time, for listening. I hope you learned something from the lecture. And everybody, please do stay safe.